Good evening, everybody. This is Yassir Al-Amri. I have with me Dr. Ali Masood and Dr. Mubarak Ad-Dosari. We are presenting from Elite Medical Center in Riyadh, Saudi Arabia. Our patient today is a 60-year-old male who is known case of diabetes mellitus, hypertension. He is a heavy smoker and he has positive family history of coronary artery disease. In 2012, he had inferior wall MI, and at that time he had drug-eluting stents to proximal RCA. He presented with recurrent chest pain lasting between 5 to 10 minutes for the last 3 days. His examination was unremarkable, and his ECG did not show any ischemic changes with a heart rate of 85 per minute and regular. His labs are normal, and his troponin was negative. His echo showed LV diastolic dysfunction with ejection fraction of around 40% and anteroseptal hypokinesia. Let's review, please, his angio start from the diagnostic.
Go back to the right.
Okay, as you see, this is his right coronary artery. It's showing the in-stent restenosis in the proximal RCA. It looks focal in the mid-segment of the stent. It's a non-dominant RCA. Next. It's showing the same in-stent restenosis. Next, please. As you see, his left system is ectatic with a dominant circ with no flow-limiting lesion. Next, please. Next. As you see, there is some disease in the ostium of the diagonal, or it could be the normal segments when you compare it to the ectatic artery. Next. There's mid-segment LAD disease and distal also LAD disease, which is significant. And you can see calcification in the mid-segment of the LAD. Next, please. Okay, stop it, please. Take slowly. Here you appreciate that the mid-segment LAD is tight just before the ectatic segment. It's the one after the first diagonal. Next. Okay, next.
So we'll go to what we did.
Now we go to Ali Masood. You can please carry on with what you did so far.
Good afternoon. Myself and Dr. Mubarak Ad-Dosari, we started with the RCA. We have chosen semi-blue wire to cannulate the RCA, and then we used the 3/0 by 15 regular balloon to dilate the artery, and our plan to go ahead with the IVUS to assess the instant restenosis mechanism, and then after we'll go ahead with stenting. It's very important to use IVUS in instant restenosis cases just to understand more the mechanism of instant restenosis and try to optimize the result to avoid the recurrence of instant restenosis. It is focal restenosis, so we need to think of mechanical problem like stent fracture, and the plan to use the second generation drug-eluting stent, which was not probably there when he has the initial intervention, which was 7 years back.
So the image you see now is after dilating the right coronary artery with 3/20 high pressure balloon. We can see that there is some disease before the stent, but it's not flow limiting. Now we'll go with IVUS to assess the mechanism of the instant restenosis. If there is any stent fracture, and if we need to dilate more the stent.
Closer. Can you put the camera?
Can
on
you
the
show the
IBIS?
IBIS, please, in the outside screen?
Okay, start, ring down. Go back. Go back.
Please,
wait,
can you
wait, go
focus
back
the
to
camera
proximate
on
signal.
the
Go back.
IBIS? Hello.
Proximate, normal signal. Go back to the normal signal. Yes.
On the IBIS, yes.
Ring down. Go
لا لا هنا هنا this one please.
distal to the lesion. So we're going to cross distal to the lesion and start pulling.
Ali, they
Now,
don't see it. We have to.
They don't
we
see
have
it.
to
So
show it
now
again.
the IBIS catheter is distal to the stent. It's a small, relatively small caliber vessel distally.
Wait until they focus the camera on it, please.
Okay. So recording slowly. Pull back. So you can see the pullback. Well opposed stent. I cannot see at this. Yeah, there is some hyperplasia now. Start to show. Still inside the stent. Okay. Pull back. Undersized distally. Oh, sorry, proximally. I mean, see the stent size proximally is small relative to the distal segment. And we're almost now. Now we are back to the
No,
proximal
it
segment.
does not
Now
show.
we're outside. So I don't
Come
see a
on,
stent
do not
fracture.
worry.
There is
Not worry. You
hyperplasia.
need to focus on the screen, please.
And
this one, then you shift it to the other
proximal
one.
part of the stent is not well deployed. So we already dilated with the balloon. And we'll go ahead with 3.0 stent.
Okay. Is there any stent fracture?
No, I didn't see any stent fracture. There is hyperplasia and under deployment of the proximal part of the stent.
Okay.
And this could explain the reason of instantly stenosis.
Let's play it again, please, so that they can see it. Start from the distal.
So just slowly, please.
Go distal. Start from the beginning of the stent. Distal. Okay, so the stent is undersized also,
Exactly.
relatively to
Yeah,
the
especially
vessel
the
size.
proximal part, yeah.
Yeah.
Distal stent.
Okay,
was good.
start it, please.
Go distal to the segment. Distal, please.
Start from the beginning. Beginning.
From the beginning, yeah.
This is not the beginning.
Go from the beginning.
Go up to the. Yes. Okay, start now. No.
Bro.
Okay, this is the distal stent. We are going proximal. And if you notice, there's undersizing of the stent and there's some in-stent hyperplasia, as Ali Masood mentioned. And proximally, the stent is under-expanded. So the mechanism is undersizing and under-expansion of the stent.
So this is
Okay.
yeah.
So what are you planning, Dr. Masood?
I think 3.0 stent should take care of this instantly stenosis. So my feeling 3 by 23 or 22 stent will cover the disease segment from the level of RV branch down to the distal part of the old stent.
So you'll involve the pre-stent disease segment.
Just starting from the disease segment, yeah.
Okay. Do you think 23 will be enough?
What do you suggest?
26.
Okay. Dr. Hussein suggested longer than 22, so we can use 26, or we can use the wire to size.
Okay, size it with the wire, please.
So
Let's measure with the wire.
The opaque part of the wire is length is 30 millimeters, so we'll pull it back
The same view.
till the proximal proposed landing. Come back.
Okay,
Test.
that's fine.
Yeah, you're right. I agree with Dr. Hussein. 26 probably will be more appropriate. So we'll take 3.026 stent.
Yes, yes.
Okay. Yes. It's always good to use different modality to assess the length of the lesion to have the proper size and length of the stent. This is 3026 Onyx Resolute. Right.
Not this one. Yeah.
Doesn't Dr. Mubarak now is taking over the probably you noticed we have chosen GR4 because we thought the lesion is not that complex. However, GR4 in general is not usually very supportive catheter, especially for long lesions. But Dr. Mubarak nicely introduced the stent to the lesion. Now I think we can pull back and test. See? What do you think? We come back shوي.
We have to know that when you use onyx stent, that the dot of the balloon is at least 0.5 millimeter away from the stent. So always make sure that you are covering the lesion very well and don't depend on the dot itself. I think this is a very good position.
This is good position. So we'll go ahead, small test again. Small test. Stent up.
We'll go to high pressure. Let's go up to 18.
16 now. 18.
And 20.
Now up to 20.
So at 20 it will be what?
20 will give you 3.35.
Okay, that's very good.
Now stent down. Let's give it time. Go. Back. See. Nice. You need to do
Excellent result. I think now that the lesion is well covered and the result is excellent.
The area of focal stenosis, you can see probably if you compare it to the other segment, probably will need NC balloon. What do you think, Dr.
Yes, I think it's a good idea to take a 3.5 NC balloon.
3.5 NC balloon for the mid segment.
3.5 by 15, please.
Okay. And then after that, we'll use IVUS again. Yes, please. It's okay. Any questions? Come back short.
Back.
Come back short. أكثر شوي حتى المكان خلص.
Okay, that's good.
So this is 3.5 NC balloon, inflated up to 18, 20.
Of course, sometimes you cannot get rid of the haziness, and again, you have to be careful of atheroma prolapse through the stent struts that can sometimes deceive you, and you keep on dilating, and you get worse and worse results.
So we inflated up to 18.
Okay, let's go cranial, please. I think this is very good result. LAO.
Just wait.
LAO. 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 Sorry, I can't.
Limited.
Okay.
Sunny.
Excellent.
I think you're okay.
Okay, let's go back with the IVAS to assess the stent expansion. Now we'll shift the camera. Yes. Okay, قول لهم. على الآيبس. Shift it to the IBUS, please. Shift it to the IBUS. Okay. You see? Very nice.
Floor, please. Thank you. String down. Okay, go.
Go ahead. Let's go. We'll start from distal with the IBUS.
That's enough.
Okay, let's go back, please.
Record.
You can see that the stent is fully expanded. With well opposition with the wall. And there's no atheroma prolapse, or I think proximal is still, that segment is still underdeployed.
We'll just take the insignificant for the proximal
Yes,
segment.
so we'll take it again for the proximal segment. This is the advantage of using IVAS. It shows you what you don't see by the luminogram.
Where is the balloon? Yes, same balloon. أنت متواضع جزاك الله خير. والله العظيم قاعد احنا نتكلم. أنت يا أخي مدير واحد يحاول يحتكك يا أخي. هذه مو بالله عشان مدير. لا والله ما شاء الله لا والله بالعكس جزاك الله خير.
I think onyx stent you can dilate it, the 3 you can dilate it up to 3.4 to 3.5.
You want to use stent was? It's good to use.
I think it's good to use.
Yeah, let's do stent was, please.
We'll use the stent post to make sure that
We are not outside.
we are not outside the stent and will not dilate the normal segment of the artery.
Sini. Sini.
Of course, the nose of the balloon, it's okay to be outside the stent because it's smaller than the real size of the. This is very good.
I mean, placed. Proximal segment, shall we do something? You see the waist and the proximal part. Sent
It's
20.
good. 24, 26.
Now 24. Down at 24. Yeah, let's do stent boost. See, I mean, stent boost will help as, like IVAS do. We can see the stent segments and make sure all well deployed and well inflated. Yeah, let him do the stent boost now again.
Push your balloon in. Push it in. Yes. Okay, that's fine. Let's go.
First and most. You go ahead.
Okay, you can see that the stent is fully expanded.
It's okay.
They can see it outside? They can see it outside the stent post? Okay.
Shall we stop it here?
All right, I think this is excellent result for the right coronary artery. Now we will proceed to the left coronary.
Final injection, please. Nice result. Now we'll move to the left system where we have more complex lesion in the LAD. Can I have EBU guide? EBU guide. It's okay.
Can you show please the left coronary?
3.5 and ACT.
Okay, next, show me the areocranial. Okay, stop it please and play it slowly to show the lesion. Okay, this is the mid-segment lesion at the second diagonal, which we think is tight. Ali, can you please just summarize your approach to this lesion? What are you planning to do?
Okay, so you can see the left LAD is diffusely diseased. There are ectatic segments with areas of tight stenosis and calcification. So it's too difficult to fix every single lesion, but our plan to go with the tightest lesion in the mid-segment. It's tight and calcific. So we'll fix it, then we'll go, and then we'll do FFR to assist the distal and proximal lesion. We did not do FFR from the beginning because this obviously very tight and patient is symptomatic and has hypokinesis on the echo. So definitely LAD is ischemic. So what we will do, we'll just fix the tightest stenosis and assist other lesion with FFR.
I think it's a large, huge LAD wrapping around the apex. Also, the distal lesion is tight, Ali. Probably if you can assist it with IFR or FFR, which is more scientific, or you can stent it, which is more cost effective. This is APU?
Yes, APU.
Okay. Will you pre-dilate, Ali, or you will go for direct stenting?
I think it's calcific lesions. I would prefer to dilate with good size balloon.
And what size of stent you think you will use?
4O.
Okay. I think at least 4O, I agree. But since there's calcification distally, what will be your strategy to avoid complications or rupture or dissection?
So you mean for the distal lesion?
Yes. No, for the same mid-segment lesion.
Yeah, we'll take it step by step. So we'll take 3O balloon and dilate and see how it will behave.
So we video call, eh? Video call over here.
What do you mean video
We'll
call?
start with the mid lesion.
They will ask questions, but
So
how am I going to hear them? Excuse me.
Can I have 3O 15 balloon, please? Or even 3.5? 3.5? Regular? Yes. شوية كبير بس
بالون
just leave this prepare the balloon. I will just put a wire and then balloon it.
Okay, this is a 3.5 by 15 balloon. We'll dilate the lesion once we cross it. It will also help us in sizing.
Come back more. Come to the proximal AD. Very proximal. Very proximal. Come back. Come back. يلا حرك كثير ومشي. Faster.
Test, please.
Maybe on a small branch. So just come back. We will
Go
come
ahead.
back.
Okay. Change the view.
Yeah.
Okay, we are in a septal now.
Yeah, go to the
Yes, let's try epiplanial.
It's ectatic vessel, so come back. خليك من ectatic segment. Come back more. More. حرك يعني خلينا نشوف التب. Go.
Just straighten your wire, yes. I think you are in a branch.
Yeah, we're in a small branch from the beginning. So let's come back from the beginning.
Okay.
So we are not in a branch, but because of ectasia, it's okay. Just go all the way down, all the way down. Go back to the. Yeah, same view. So we'll take 3.5 regular balloon by 15. It will help to dilate the lesion as well as properly size the area of stenting. This lesion looks very tight, so I probably agree with Dr. Hussein. Maybe we don't need to do FFR. We can just fix the mid and then assist the distal for possible stenting as well. Sorry, the mid segment. Just mid segment. I have connected.
We are sorry that this is a one-way conversation. Probably we can have some questions later on because we can't hear you.
Communication now.
Otherwise, it will be very good to listen and hear from you and share your experience with us.
Test. Come back to the mid. Is this the same angle?
Down, go down, please. Yes, that's good. Test now. I think this is a good position. Back a little bit.
Come back.
No, you need to engage well.
Pull clockwise. So just
Back a little bit, yes.
15, it's...
I think this is good.
Okay, small test. Small test. Okay, I will go ahead with the balloon. This is 3.5 balloon. Oh, slipped because of the severe calcification, so I'll go slowly. Just come back. Test. Okay. Put it back slowly. Balloon inflated slowly this time. I just want to make sure that it will not slip again. It may slip because, yeah, you need to bring it back more. Just bring it more. خليك تبدأ على test. Yes, thank you. No, go inch. That's it. I think we catch the lesion. The lesion is fully dilated, So keep the balloon there. Let's do Sini, and then we can see the length of the lesion. Sini. I think we need to go شوية in.
Yeah, you can go back in and dilate again.
Yes, that's it. Test. Engage with her, please.
Once you inflate, take advantage of that and engage very well.
Balloon inflated again. Yes. Slipped again. So تبغى تنفخ وامسك لك small test, please. Good distance. Okay, go ahead.
I think Ali, we can.
I think that should be
Okay, that's very good.
That's
now.
Okay, well, this
Enough.
is fine. Okay, down.
Test while the balloon is there to make sure
okay,
there's
we'll
no
see.
perforation or leak
Okay,
or
we will
anything.
Sini, but let me just. Yeah, معلش. Ready for Sini? Sini, go ahead. Inject. Good injection. Thank you. So.
Okay, let's take the balloon out.
Yeah, probably 16 or it should be fine, huh? Stent.
Yes.
Can I have 4016 please? معلش الألم عشان توسيع الشريان. Patient has some pain. That's indicate this lesion is coming.
18 is good.
Give us
18 is fine.
18 is fine. For O by 18.
4 by 18 stent.
Yes. Pressure. Can you give nitro, please? Pressure is 170.
Give the intracoronary nitro.
Can I have 200 nitro?
Trideal. Yes, please.
Yeah.
Let's give him 200.
كيف الألم الآن؟ You are touching his face. Can you just radiographer Muhammad, please?
Because the size of the proximal to the lesion is larger than distal, so we'll go nominal with the stent balloon, and then we can both dilate with a 4 or 5 balloon inside the stent to avoid oversizing distally or dissection.
This is a good size. I mean, good position. City. I think we're in good position. Sorry. Okay.
We'll see you again to see the position.
No, there's a problem with
The engagement is not good.
No, not the engagement. It's disconnected because there is no bubble. There is no bubbles.
There's leak.
It's okay. It's okay. Rest up. Engage with the wrist. It's always very good to have good support.
Probably 3-5 would have been
Yeah.
better than EDU in this case. Okay, Cindy, let's see where was. You need to go down.
That's it.
Test. Good test, please.
Should be okay.
I think this is good. Go ahead. Nominal, it's nominal at 12.
Stand up. Should it move or
Test, please.
small
Test.
test? Small test. Oh, okay.
I think it's fine. Go ahead.
This is 4.0 stent, so as Dr. Amri said, it's good, it's a big size stent, so we need to make sure that.
See me that, please.
What's the nominal here?
12.
Now we're 12.
Okay, I think this is good for the distal.
Exactly, yes.
Then we can post-dilate the proximal part. He's having chest pain, so the culprit lesion is the LAD. Every time we inflate, he has chest pain.
Take it down. Yes. And Seni. Seni. We will give nitro now and see. Nitro 200, please. Nitro 200. Technical now.
Always when you dilate a tight lesion, you start seeing that the other lesions are more significant. We'll deal with the distal lesion and we can later on assess the others. So Ali, for how long you will treat him with dual antiplatelets?
I will stick to the guidelines. Still, I will keep him for 1 year since there is no contraindication of the antiplatelets. So I will keep him for 1 year and possibly a longer term because he has diffuse coronaries and ectasia. So at least 1 year, and probably I will keep him longer than this. Has been shown that 30 months is superior to 12 months. However, with the newer stents, that if you need, you can discontinue with the antiplatelets even after 3 to 6 months.
Will you consider giving him antiplatelets, dual antiplatelets for life, since he has significant coronary ectasia?
For me, yes, I will consider this.
Of course, there is no standard treatment for coronary ectasia, but I think giving dual antiplatelets for life is a very good option.
No.
What do you think of the distal now?
So I think the distal, if you compare it to the original view, it's the same. That segment, but there is focal area of tight stenosis at the small diagonal. So either we deal with this with short stent, probably 2.5, and then leave the rest for medical therapy. This is one possibility. We can definitely do FFR, but my feeling that this short area of stenosis need to be fixed because it looks tight to me.
Yeah, I think it's tight. It's a huge LAD wrapping around the apex. Definitely, I prefer to dilate it and stent it. So probably we need some redilatation since it's calcified.
Okay, so can I have 2.5 15 balloon, please?
Yes.
Regular, yes, please. Take the. To 515 balloon. They're just focally that area. 12, sure. 50 outside. Give it more. Give it more. Alhamdulillah. So the patient is fine. He used to have some pain with the LAD dilation, but now he's fine.
Will you consider doing IVAS, Ali, for the
It's always good to do
LAD
IVAS.
since you have the
Yeah, of course.
catheter open and you have the facility?
Sure. I mean, it has been shown in several studies that IVAS-guided interventions in general associated with better outcome on long term with regard to instant restenosis and stent thrombosis. So since we have the facility, we're going to use it, inshallah.
I think every time you do IVAS, you find that you undersize the lesion, even though angiographically it looks oversized.
I think this is okay. So this is the distal lesion, 2.5 balloon for inflating. Can this test for me?
I think you dilated it.
Did we I think we moved
Died.
Okay.
Just come back short.
Pull back a little bit and inflate. Yes, this is fine.
خليك مرتاح يا عم خليك مرتاح. Yeah. So this is the area. In fact, looks
Let's
big.
go
and
for high pressure.
This is 12 now. 14.
Okay, now it's fully dilated.
Can you see?
Screen? Is it? All right, that's good.
So I'll probably take 275, 15 or 12. Yeah, that.
I agree with you. I think 275 is a better option.
Yeah. So can I have 275, 14 or 15 stent, please?
275, what do you have?
5 by 15.
15 is good. I like the sizes of Onyx. Because you have 15, you have 18, you have 22, 26, 28, and then so on.
Though Dr. Mark is doing all the work, he's quiet. He likes to work probably in quiet environment. So we're just talking and he's working.
It's easier to talk than to work.
Can you just concentrate on the distance, please? Looks longer than I expected.
No, it looks longer, believe me, because of the look at the dots of the balloon compared to the stent. Always Onyx looks longer than you think, but the size is very good.
This is fine.
This is
very
excellent
good.
size.
افتح يا عم.
And this is what I was talking about. You can see that there's a good distance between the dots of the balloon and the stent.
Nominate one. So
Yeah,
we are 12 now.
I think we need a high pressure balloon. Let's get high pressure balloon. 12,
Down.
275 by 12.
Yeah, the tightest area is still not well inflated. You can see that's clear.
Yes, please.
So we'll take high pressure balloon and we'll use boost to help to figure out the area of narrowing.
How many minutes now after the last dose of heparin? Just remind me of his weight, please.
275.
And his weight is what, sorry? Weight? 69. So we give him 10,000, which is very good. No. It's enough. We'll just do ACT afterwards. We'll dilate the stent now with 275 by 12 high pressure balloon.
Can you do boost? Please come back. So using boost, save contrast and.
I think you need to pull back before the boost. Pull back, please.
Ready? Okay.
Pull back, pull back. I think this is fine. Go ahead. You can go in a little bit if you want, or you can inflate, because the nose of the balloon is outside, which is fine.
Looks okay to me.
Yes, go ahead.
So we'll just go ahead with the emergency balloon. Nice. So now it's 16.
Let's go to 20, 24. We always go for high pressure,
Yeah, 20. will
because
make it
whatever pressure you go up to, this balloon will not expand more.
So this is.
Okay, this is very good expansion. It's fully expanded, as you see.
Give me an after, please. 200. Nitro, please. Put it in the middle, please. So we'll give nitroglycerin and we'll do angio and then we'll do IBUS.
Okay, ready for us.
ارتاح يا عم ارتاح.
Can you shift the camera to the IBUS, please?
Can you concentrate? Put it in the middle, the distal lesion. The distal lesion, put it in the middle. Thank you. Yes, sir. Push the wire, please. No. Now we need to see the catheter, please. You can go abicranial, then you can see the whole vision. Push the wire more, please. Push the wire.
Going to a branch. As you notice, there's diffuse disease in the LAD.
Okay, you are distal to the lesion now. Can we see the IBUS, please? Okay, thank you. Start pull back, yes, record.
Which part is this, Ali? This
Distal
is
stent.
distal stent.
So we're evaluating distal stent with the IBUS catheter. You can see still we are distal to the stent. Now you can see the stent. Smallish stent in comparison to the vessel size. We already dilated with 3O and there is lots of atheroma. And it is followed by moderate or mild disease, but I don't think we need to do anything for that. Go ahead. Go ahead. And this is the proximal stent, well opposed.
What you see is a significant atheroma around the stent. But I think proximally you need to inflate it, or the mid-segment. You need to inflate it with a 4-5 as we planned initially. I think the distal stent needs to be inflated with a 3 and the proximal with 4-5. So let's get 3 by 12 balloon, high pressure.
Can you put something here? Condom, please.
Condom catheter, please.
Condom, please. Condom.
You have the way now? Give it to him.
So we'll start with the distal lesion. This is 3O NC balloon.
كم باقي؟ لازم لا أكثر. I think باقي 10 minutes. لا we still will discuss. I don't know whether we can receive questions or interactions from the audience.
Go to the area was better.
Muhammad, can we interact with them or no? We cannot interact with them.
حط لك اياه ارتاح حط لك اياه.
ما بسمعنا ولا يسمعنا؟
Can you boost please? خليك مرتاح هاتف هو.
It's good to utilize whatever facility you have to optimize your outcome.
Send the boss.
Yes.
Sini.
Go ahead, send.
It's good, I think. Go ahead.
This is 30 NC balloon. Remove this. 14, 16, 18, 20, down. And then we're going to use 4-5 NC balloon for the proximal segment. Let's do one boost just to follow on. Let's just keep it there. Do another boost, please.
Okay.
Go ahead.
It looks fully expanded.
We can pull this in slightly and.
You can pull back and inflate again, yes.
So pull back. That's it.
4, 5, 5,
I
20.
will just dilate the proximal part
What,
of it
what,
again.
sorry, that was the size of the 4, 5? 18?
20.
No, it was 18 or what?
I think this is enough. We
Okay, then 4, 5 by
inflated the region
15.
with 30, 12 up to 20 atmospheres. Can I have 4, 5 NC balloon?
Yeah, a balloon? No, 5 is too big. What do you have?
4, 5, 12.
12 you have? 4, 5. Too big. Okay, we'll take 5. Okay, let's see and see how's the distal result. You did the sunny? Try. Okay. We'll take a 5 balloon. So. Okay. I think it's very good. Okay. Or at least dilate the other stent now. It looks oversized, but I think when you do IVUS, you see that.
Yeah, and because of the distal disease segments proximal and distal to it.
Yeah.
And as we agreed, you cannot go after every single lesion. Our target to just deal with the tight stenosis that can cause ischemia.
Can we get rid of the diagonal branch, please? Try to go AP cranial. Okay, that's enough. Let's see now. So that we see the whole stent. Okay.
That's it. Stent boost, please. Sorry.
I think we need to pull back a little bit. You can see the significant calcium around the stent.
So we need to be careful with this.
Test now.
Boost.
I think this is good.
Yeah, we're fine. I will just go slowly, as Dr. Amri said. There is significant
Yes, ma'am.
calcification, so we would like to optimize the result without having complication, inshallah.
Nominal only. It's nominal at what?
12,
Okay, that's fine.
down.
This is a 5O balloon.
Now let's do boost again, please. Keep it, please. Boost, please. Prepare nitro, please.
Okay, that's good.
This is the one?
Is it the one down?
Second one, we didn't do. It's the first one? or
Sure,
second?
the second one.
So we will give
Okay,
nitro and
do
do.
stent boost again. Okay, let's see any
Oh,
stent
wait,
boost.
no, go back with the balloon. عشان السنت بوست. هذه هي.
It was not boost. هذا آخر واحد. No, go back with the balloon. Go back with the balloon. Let's see.
Let's see.
This is it? After dilatation? Okay, that's fine.
Boost
Yes.
again.
Okay. All right.
This is the one.
Yes.
So still there's some calcium in the.
I think you cannot overdilate it, otherwise you will have
Exactly.
complications.
So and the lumen of this is for already 4O stent dilated up to 5. So I probably will accept this result in order to avoid possible complication over dilating calcific area. So let's give nitro and do injection.
Also, probably if we overdilate, we will damage the stent also.
This is 200 mic nitroglycerine. Sorry. You're okay. What do you think, Dr. Hussein?
I think this is excellent result. Of course, when you dilate the lesions, you start appreciating the other diseased areas. But as you said, we will not follow every area. I think this is excellent result. There is very good distal flow, and I will accept it.
Go take the wire and we'll do the cranial, please. Ready?
Excellent.
Thank you.
I think this is very good result.
Okay. Thank you very much. ما في discussion ما في discussion
I don't know whether we can have questions or discussion or comment from the audience. Any comments? Any suggestions? It's a one-way interaction.
Send your question, yeah.
So Ali, from your experience, how often do you see coronary artery ectasia?
To be honest with you, we see it every now and then, especially with in smokers. And we always have dilemma dealing with these lesions because it's too difficult to find proper sized stent. And one of the technologies sometimes that we use in these cases, self-expanded stent, where it can take the shape of the artery. It can take the shape of the artery. However, the evidence for the self-expanding stent is not as robust as the drug-eluting stent that we are using on a daily basis. But definitely this is one of the modality tools that we use, plus good medical therapy. As Dr. Hussein suggested, long-term or lifelong antiplatelet, and sometimes anticoagulation if patient present with extensive thrombosis and blood sclerosis.
Suppose there is a thrombus in a huge ectatic artery. What will be your approach for that?
If there is big thrombus, usually we don't like to intervene with it immediately. Sometimes we just keep the patient for 48 hours or even more on IV antiplatelets and anticoagulants to reduce the thrombus burden, then bring the patient back and try to localize the area of significant stenosis and fix it.
Thank you, Ali.
أنا مبسوط حتى لو ما في أحد يسمع إني قاعد انتراكتنج مع
الله
حسين.
يخليك.
الله العظيم.
يعطيك العافية.
جزاك الله خير. معليش شغلة ان شاء الله خير. لا بس ما يصير، ما في انتراكشن.
ما في انتراكشن، استنى.
محمد.
الحمد لله على السلامة. أخي الكريم، الألم اللي حيجي طبيعي. طيب السبب إن الشريان كان ضيق اتساعه بس واحد، احنا نفخناه إلى 5، يعني 5 أضعاف. طيب فمتوقع إنك حتحس الشد أحيانا يستمر إلى مدة أسبوع، بس الألم هذا غير على الألم اللي كان يجيك، صح؟ أيوه، شايف هذا السبب، الشد داخل الشريان، يعني شريان تقريبا مسدود نفخته من 1 إلى 5 أضعاف. اوكي. No, definitely not, since as Dr. Masood commented earlier, we will not go after the other lesions since it's diffusely diseased, and we think probably this is the normal segment with some disease in it. So we prefer not to intervene with the other segments. You know, whenever you deal with ectatic coronaries with diffuse disease and you dilate the tight lesion, you will start appreciating that the other lesions looks tight. So the best is to go for the significant lesions which are causing the symptoms of the LV dysfunction and leave the others for medical treatment. Thank you for the question.